Welcome back. I'm Shannon from the Arthritis Patient Advisory Board at Arthritis Research Canada, and we have the privilege of having Adam Huber here with us for this interview. Adam is giving a talk tomorrow on juvenile dermatomyositis and new developments and changes in research approaches. He is professor of pediatrics at Dalhousie University, and he's a pediatric rheumatologist. And your main gig is at the IWK Health Center in Halifax. Can you enlighten us as to what you do there and what that center does?
Sure. So the IWK Health Center, which is named after Isaac Walton Killam, who was a benefactor, I think 75 years ago or so, is the regional children's hospital for the Atlantic provinces, so Nova Scotia, New Brunswick, and Prince Edward Island. And at the IWK, I'm a pediatric rheumatologist, so I see kids with a variety of rheumatic diseases, including lots and lots of arthritis. But the reason I'm here at the meeting is to talk about another illness called juvenile dermatomyositis.
Now, could you elaborate on what that is? Because I would like to learn about what it is myself.
So, juvenile dermatomyositis is one of the systemic autoimmune diseases, and it's particularly characterized by a combination of muscle involvement, which causes kids to have either weakness, muscle endurance problems, and essentially functional problems, and some very typical rashes where they get sort of scaly red rashes on their hands, around the eyes, a variety of other places. And then rarely kids will develop much more serious complications in terms of there can be cardiac involvement, there can be bowel involvement, there can be other sort of really serious things. But most kids, it's an illness of muscle and skin.
And does that, depending on the management, get worse as they age, or?
Interestingly, so juvenile dermatomyositis by definition involves children. In adults, there is essentially an analogous illness called dermatomyositis. But there probably are some significant differences, one of which is many kids actually get better with treatment. A significant number will go into a long-standing remission. Some kids will come off all their medications and never have another problem. It tends to be more of a chronic disease in adults, but there certainly are lots of kids who will continue to have problems. But it doesn't tend to be the kind of thing that accelerates or worsens over time. Although, if we don't find successful treatment, it certainly can cause increasing problems over time.
Challenging while they've got it, I'm sure.
The kids can be very, very sick. It really does range from kids who have a little bit of mild rash, a little bit of mild weakness, up to children who are profoundly ill in the ICU. There's a huge range.
Yeah, very scary. So can you tell us a little bit about why you got involved in rheumatology?
So I think like most people who have gone into various specialties, they can almost always point to either an individual or an experience that they had. That was really sort of the precipitant of them going into that field. And so I had, when I was a pediatric resident in Ottawa, at the Children's Hospital of Eastern Ontario, I had an amazing rotation with the pediatric rheumatologist that was there at the time, which very much turned me on to basically going off and doing a fellowship and additional training.
So you've been involved in pediatrics from very early on?
I went directly from medical school into general pediatrics, and that would be sort of the standard training. There isn't really a rheumatology and then pediatrics route. It's really the other way around.
Okay. Now, what do you think is the most exciting and important thing that will come out of the CRA for you, or what are you looking forward to taking away with the Building Bridges theme of the meeting?
One of the things I'm going to highlight in my talk tomorrow is directly related to the importance of actually building collaborative relationships, which is my interpretation of the Building Bridges theme. Juvenile dermatomyositis is not a common illness. It affects about 2.5 per million children. So this is not the kind of thing where even the biggest centers have enough patients to really conduct clinical trials, to do the research that we need to understand the causes or better treatments, etc. So basically the formation of collaborative networks is absolutely critical. And so that's one of the things that I'm focusing on, and is really changes in research approaches part of the talk, based on the title that you read earlier. Ultimately, we're going to get very, very much further if the groups that are in the UK, the groups that are in Italy, the groups that are in Japan, the groups that are in Australia are all working together in the same direction rather than us all trying to invent the same wheel.
And benefit patients in turn, internationally.
In many ways, these are illnesses that affect kids everywhere.
Yeah.
And because they're rare, more often than not, people don't necessarily recognize them early. People don't necessarily
That's what I was going to ask you
understand.
about diagnosis, how difficult it is to get how challenging it is to get a diagnosis.
It almost certainly depends where you are. So if you're in a place where you have good general pediatricians who have access to good pediatric rheumatologists, I think the diagnosis actually happens relatively quickly. If you're in a place where people don't actually have that sort of broad background, they don't have access to people who are specialized in this stuff, it's going to be very hard. The average family doctor may never see a case of juvenile dermatomyositis. They might see a case of adult dermatomyositis, and they might recognize it because they do look kind of similar, but it certainly is a huge challenge, and delays in diagnosis are certainly one of the focuses that patient groups in our area are really concerned about, for sure.
So you're in touch and work with those patient groups.
Absolutely.
And so I would think in children's healthcare that patient-centered, healthcare or a patient-centered approach would be even that much more prevalent, hopefully, but is it?
I'm not sure I would say that it was either more important or more prevalent, because I think it's critically important in both adult and pediatric care. In many ways, it's somewhat different in the pediatric world because the average 4-year-old doesn't get to take much control of what they are experiencing. And so I think we try very hard to make it about families and about our patients. But the reality is that the kids don't get much of an input simply because they're often at an age where they aren't developmentally appropriate. But again, it is certainly, I think, extremely important that this is all about the family experience and the family understanding what decisions they need to make and having all the information they need and feeling supported, and really organizing our clinics, organizing our work in a way that facilitates them taking control of their illness.
So where do you see arthritis care and research going in the near future, especially in your field?
So in dermatomyositis, in many ways, we're well behind where arthritis would be. And that's not surprising, really. There are many, many more patients who have arthritis, even in children. And then if you look at in the adult world, there's, again, 10 times more. So there certainly are huge areas where we need a lot of work. We don't really have that good an understanding what the underlying causes of dermatomyositis are. We're working hard to improve treatment, but the reality is our treatments are still at the point of more side effects than we would be happy with.
Right.
And a lot of the work that we're doing right now is essentially infrastructural work, groundwork. So organizations like the Children's Arthritis and Rheumatology Research Alliance, which I do a lot of work with, which is a North America-wide group, working with our colleagues in the UK and our colleagues in Europe, and basically putting together these networks where we have registries that can talk to each other. We have the ability to sort of collect patients from multiple centers to get the kinds of numbers that we need, whether it's for genetic research, whether it's for clinical trials, whether it's for observational type research. And so it really, in the dermatomyositis area, which is where I do most of my work, the next steps to what is better treatment or what is the underlying cause, we're right now just at the point where I think we actually have enough infrastructure to basically be really starting to move in that direction, as opposed to arthritis, where you could really say that there's been a sea change in treatment over the last, say, 10 to 15 years.
As much as there's been a change in treatment, do you think that juvenile arthritis kind of has a PR problem? So many people they think of arthritis as an old person's disease, so even someone who's younger that has a type of inflammatory arthritis or gets early onset osteoarthritis, that, very small children can get these diseases.
There's no doubt that awareness that arthritis is not just a problem of old people is a problem. Although at the same time, it's a problem that I'm somewhat insulated from. Really, in my world, everybody knows that kids get arthritis.
Right.
Really, I go to meetings, I talk to my colleagues, I go to work every day, and in that environment, everybody knows that kids get arthritis. I would say probably half of the families that I see where they're basically coming for a diagnosis of arthritis, I would guess half the time they're surprised to discover that, well, lots of kids get arthritis and it's not that uncommon. Often by the time they've gotten to us, they've seen a family doctor or a pediatrician who's already said, gee, I think your child might have arthritis. I think to some extent, the bigger problem is the more societal piece and whether resources are dedicated to identifying, treating, understanding causes of arthritis in kids, which certainly puts me in a bit of a situation of a conflict in that. Really, I look after these kids. I would like there to be more money dedicated to that study. I'm also smart enough, and I also recognize the fact that my patient numbers are 1/10 of the adults who have rheumatoid arthritis, and those numbers are 1/10 of adults who have osteoarthritis. And so it's very difficult for me to say, oh, we should have lots more resources, when I recognize that there are lots and lots of people who also have a problem, who also need research, who also need resources. But of course, I would like more money dedicated to my area. I can't deny that.
Well, do you think, like, in the future, that because there's so much crossover, that the more research, no matter what age group it's being done on or where it's being done, there's kind of a domino effect that can happen and cross over into other forms, and just more knowledge, period, begets more knowledge, with it?
There's no doubt that that is at least in part true.
Yeah.
When we certainly look at, for example, some of the genetic studies, the same genes come back to again and again and again, whether it's rheumatoid arthritis or lupus or juvenile arthritis. Unfortunately, there really are significant differences in why one person gets lupus, why one person gets juvenile arthritis. We still need to understand. So I think it is true that everything that we learn about individual autoimmune illnesses tells us something about how the immune system works, how the immune system fails to work. But we still do need the pieces that sort of drill down to understand, well, why do these exact same genes in this person give us this disease? Why do the same genes in a different person give us a different illness? And whether those are environmental factors or there's other genes we don't understand, or maybe there's some other factors, those are important. But I do think it's correct that certainly in the area of other autoimmune diseases, that the research done in RA certainly benefits my kids who have juvenile arthritis. There's no doubt about that. Many of the treatments that we use now routinely were first developed, tested, and understood in adults, and then 5 years later they end up in our clinic. And I'm sure that's certainly a pattern that's going to continue with the new small molecule inhibitors or other medications like that.
So that being said, since you mentioned the 5-year mark, what is your hope for your patients over the next 5 to 10 years?
So if we're sort of keeping the discussion to dermatomyositis, the sort of holy grail of treatment right now is to not use, or to use much less prednisone. Unlike arthritis, where prednisone is either a very small component of treatment, or in kids, no part at all, kids who have dermatomyositis are usually on steroids for a minimum of a year, which for a growing child is a very big deal.
So that's an issue with bone?
It's an issue with many things. Certainly
system.
Bone strength, growth, blood sugar, blood pressure, cataracts, skin stretch marks.
Wow.
There's literally a textbook of side effects that you can talk about with steroids. And unfortunately, many of those side effects are magnified in children because they're actively trying to grow and develop and do all the stuff that children are supposed to be doing. So I'm not sure if it's realistic to say that we'll be at the point where we actually have either a replacement or something that allows us to use steroids for a much shorter period of time. But that would certainly be my hope, is that that's the direction that we're moving in. And there certainly is some work being done that may lead to that. we never quite know when you're going to have a home run, though.
Is there, I was just personally curious about prednisone use in children. How does it differ vastly from prednisone use in adults, or with the side effects and the
So I obviously don't treat adults. I do know that prednisone is not infrequently part of treatment in rheumatoid arthritis, often in relatively small doses. It would be fair to say that in children we don't use prednisone, with the exception of children who have a particular kind of arthritis called systemic juvenile arthritis. Although even then, we actually have some new drugs that actually can avoid steroid. And then occasionally we'll have kids who are just so horrible at their diagnosis that they may use prednisone as a bridging medication while we wait for their methotrexate to kick in or their biologic to become
drugs
available.
that can take a couple months to get full effect, or
exactly.
Gives them
Unfortunately, most kids, as in the adult world, will start methotrexate. We know that methotrexate has no impact whatsoever for at least 6 weeks, and probably not its full effect for up to 3 months. And so a patient who's at the point where they can't attend school, they can't do sports, they can't live their life, is in a circumstance where, you know what, we will accept side effects for a couple of months while we kind of get you there, because really we want to get you back to your life. That's often the most important thing.
The light at the treatment tunnel.
Unfortunately, it would be nice if methotrexate wasn't so slow.
Yes.
It really is a painfully slow medication.
The things that you need to start working right away, of course, don't. Did we have any questions from our online audience?
There are 2 questions. So what lifestyle tips do you have to offer to those patients living with juvenile dermatomyositis, and how can a parent tell that their kids may be experiencing the disease?
Okay. Why don't we talk about the second question first, because that's actually a much easier question. So depending on the age of the child, weakness is either very, very easy or can be extremely challenging. In your 10 or 12-year-old boy or girl, it's not uncommon that they can say, I'm more tired, they're having a harder time going up and down stairs, their sports performance has fallen off, they're having more difficulty getting up off of a chair, or if they're sitting on the floor, getting up off the floor. It's much more challenging in a 2 or 3-year-old child to say that this child is weak, and whether they are weak or tired or lazy or difficult or just obstructive can be very, very challenging. And even in the clinic, sometimes it can be quite difficult to decide whether kids are weak in that way until they get to the point where they literally can't sit up in bed, or they're sort of profoundly weak. And we certainly see children where they've been getting weak for 6 months and nobody's noticed until they somebody realizes that, well, gee, they can't walk up the stairs anymore. They used to be able to do that, or something like that. Many of the kids that we see, people have recognized the rash, because rash is relatively obvious. And it tends to have fairly typical patterns where the children have what almost looks like psoriasis. It's a red, scaly rash, and it's typically over the knuckles of the hands. And that would sort of be one of those signs that we sort of look at as it's considered to be almost diagnostic of dermatomyositis. I'm not sure it's totally true. And there's also a rash around the eyes that's a little bit more subtle. That's called a heliotrope rash, which again is also considered to be quite typical of dermatomyositis. The combination of being rashy and being weak would certainly raise dermatomyositis as a prime potential diagnosis, and those are certainly the kids that we like to get into our clinic early. Unfortunately, sometimes they end up in clinics of people who are not as familiar. We've actually had a few kids being managed for either eczema or psoriasis, sometimes for months, before somebody realized that, they have rash, but they also aren't doing as well in their hockey or whatever their sport happens to be. Or
delaying treatment.
And we certainly have seen some kids with some fairly substantial delays. Now, coming around to the first question about about sort of lifestyle things, there are some things that are really important in dermatomyositis. And interestingly, some of those are things that have changed relatively recently. Historically, children who are diagnosed with dermatomyositis were basically told to stop all their activities, stop all their sports, sometimes even put on bed rest, because there was a concern that when the muscle was inflamed, being physically active could actually exacerbate that, make the inflammation worse, cause them to flare. And that was actually sort of the conventional wisdom up until probably 15 or 20 years ago, which isn't really that long. And slowly we've actually come to the realization that there's probably no reason to suspect that being active will actually cause the muscles to flare or become weaker or become damaged. And in fact, there's probably good evidence that says that the kids actually require the physical activity to actually regain their strength and to regain their endurance.
To maintain muscle mass. And,
In fact, it's actually not even maintain, it's actually build it back.
Build it back.
These are kids sometimes who've become so weak they can't sit up in bed. If they want to get back to playing basketball or they want to get back to doing whatever activities they normally do, it's not reasonable to simply say, well, we're going to give you prednisone, we're going to turn the inflammation off, and then you're going to be back to normal, because they've lost muscle mass, they've lost muscle strength, they've lost all that important stuff. And so physical activity has become a absolute critical piece, often guided by a physiotherapist with expertise in that area. Second thing that turns out to be really important from a lifestyle point of view is actually sun exposure. And not dissimilar to illnesses like lupus, the rashes and dermatomyositis can actually be quite photosensitive. And so avoidance of excessive sun exposure becomes really, really important. In fact, there's even some evidence in both lupus and dermatomyositis that getting a big dose of sun can actually flare the disease. And there actually are immunologic processes that have been documented that sort of explain
just from the sun.
Purely from the sun.
Wow.
There's actually some very, very good science that's actually not only said, yep, this is sort of scientifically plausible, but here's actually the mechanism where the sun does this and it leads to that, leading to this, leading to the flare of disease. And actually we certainly will see some kids where they've made a trip to some place very sunny, gone to Cuba, gone to South America somewhere, often on vacation, and while they're on vacation, all of a sudden these rashes they've never had before come out. And there's actually also some data from one of my colleagues in the US where dermatomyositis is somewhat more common in sort of the southeast than if you compare to the northwest, for example, where they don't see the sun quite as often. We also emphasize the importance of a good diet, not in terms of specific foods to avoid or specific foods that you should be taking, but maintaining essentially a good, broad, appropriate nutrition. When the kids are on prednisone, we certainly need to be very cautious about excessive weight gain. And so we do talk about the importance of healthier eating. And unfortunately, as you may be aware, when people are on prednisone, they don't want carrots, they want a bag of chips. And so eating 100 bags of chips versus 100 carrots has its complications.
Alternatives.
We spend a lot of time, really our patients often will meet the dietitians to talk about, I'm hungry
approach.
all the time.
Yeah.
How are we going to get around this?
Yeah.
Because what we don't want is for our kids to gain 50 or 100 pounds in the first year, which
That's
we certainly
awesome.
have seen.
Yeah, I mean, to have a dietitian brought in, when that's occurring is really key.
It's certainly one of the advantages of being in a children's hospital.
Yeah.
Really, we function as a multidisciplinary team. Right? As part of our team, all the time we have nursing, we have physiotherapy, we have occupational therapy, we have social work, and then we have access to the resources of full children's hospital. So we have child life, we have dietitians, we have the various medical specialties if necessary, we have the various surgical specialties if necessary. And it really is important that these patients, because they are complicated, are being looked after by a multidisciplinary team.
Well, that would be key. Thank you so much for sharing your expertise with us and, raising the flag for parents out there so that they can identify these things and sharing with the patient community. We love to have the ABN here at the conference to expose this information to people on the street that otherwise wouldn't have access to it. So thank you again for your time.
Thank you.